My name is Haley Davis, and this is my thesis, The Efficacy of the PEAK-T module for transitioning individuals from traditional applied behavior analytics services to acceptance and commitment therapy. So autism spectrum disorder, or also known as ASD, is known for its three core deficits in delays in communication, impairments in social interactions, and/or repetitive displays of interest and behaviors. 1 in 59 children are diagnosed with ASD in the U.S. Applied Behavior Analysis Therapy, or ABA, is one of the most common evidence-based practices for individuals with ASD. A common behavior analytic approach is the discrete trial training, also known as DTT. This consists of a one-to-one instruction where complex skills are broken down into sub-skills with mass trials and consist of 5 components: the cue or an SD, prompt, response, consequence for the response, and an intertrial interval. Due to the core deficits in ASD, particularly the social impairments and delays in communication, verbal behavior therapy is a common target for individuals with ASD. And this is due to the inherent social nature of verbal behavior, where Skinner defines it as a relationship between listener and speaker, where the listener mediates what the speaker is stating, and the listeners are often composed of an individual's verbal community. So relational frame theory, also known as RFT, is a psychological conceptualization of how human language and cognition is developed. RFT accounts for this development through treating language as a verbal behavior that is established through deriving stimulus relations. Hayes describes deriving stimulus relations as learned operant behavior that do not solely rely upon physical properties of the stimulus from between 2 or more stimuli that have not received direct training. So deriving stimulus relations is obtained through mutual entailment, combinatorial entailment, transformation of stimulus function. In addition, a large component of the RFT is families of relational frames. These frames consist of coordination, distinction, opposition, comparison, hierarchical, temporal, spatial, conditionality, and causality, and deictic. One curriculum that incorporates the concepts of RFT and DTT is the Promoting the Emergence of Advanced Knowledge Relational Training System, also known as PEAK. This treatment package consists of a series of assessments and curriculum built in that is derived contingent upon the results from the pre-assessments, and this includes 4 modules: the direct training, generalization, equivalence, and transformation. Acceptance and commitment therapy, also known as ACT, is acquired from RFT and derives its practices from behavioral principles that are applied to human language and cognition. ACT attributes human suffering to experiential avoidance, cognitive diffusion, dominance of the conceptualized past and future, limited self-knowledge, attachment to the conceptualized self, and lack of values, clarity, and contact. So ACT's target is to increase psychological flexibility, which is ability to contact the present moment more fully as a conscious human being, to change or persist in behavior in order to serve value ends if the situation is appropriate. So ACT consists of a hexaflex with 6 components known as acceptance, cognitive diffusion, present moment awareness, self as context, values, and committed actions. Accept, Identify, Move, also known as AIM, is a comprehensive curriculum incorporating mindfulness, ACT, and ABA to address the social emotional needs of individuals engaging in problematic behavior and experiencing social discomforts. And this curriculum includes an introduction to behavioral principles, a how-to guide for using AIM, 75 mindfulness lessons, 175 scripted daily lessons with coordinated worksheets, the ACT quantitative analysis scale, also known as AQAS, and the Children's Psychological Flexibility Questionnaire, known as the CPFQ. With ASD, it has been found that there is a significant higher chance of depressive symptoms compared to their peers without ASD diagnosis. Furthermore, mothers of children with ASD were 28 times more likely to report suicidal ideation in their children than mothers with neurotypical children. However, despite these higher reports in social emotional needs, there is currently a lack of research for talk therapies that address these needs, as well as a lack of research for transitioning individuals from a highly structured DTT service setting to a less structured talk therapy setting to address these social emotional needs. Therefore, the purpose of this study was to evaluate if formatting ACT into the DTT format present in the PEAK-T module was effective in reducing problematic behaviors in session, increasing AQAS scores, and increasing psychological flexibility. This study consisted of 3 participants, Ben, Lizzie, and Peter. Ben was an 8-year-old who had received 2 years of services with DTT and 1 semester of ACT. Lizzie was a 6-year-old who had received 1.5 years of DTT services with no previous contact to ACT. And Peter was a 9-year-old with 2 years of previous DTT services and 1 semester of ACT services. All of these services were conducted within a Midwestern clinic within a university setting. Some general procedures for this study consisted of psychological flexibility assessments that were conducted prior to baseline, before intervention was began, and then prior to the return to baseline. AQAS scores were tracked for each session in which an individual engaged in ACT curriculum. Additionally, the frequency of problematic behaviors were tracked within each session. For Ben, this consisted of noncompliance, off-task behaviors, and verbal outbursts. Lizzie consisted of verbal outbursts and off-task behaviors, and Peter consisted of inappropriate speech and off-task behaviors. Following the first session, each following session consisted of a review of ACT. So this consisted of what the ACT acronym stood for, listing the 6 components of the hexaflex, and defining what the hexaflex component being targeted for that day. This study consisted of 3 phases: baseline, intervention, and return to baseline. Initial baseline consisted of implementing 1 daily scripted session from the AIM curriculum. Intervention consisted of a PEAK-T program that formatted ACT into the DTT structure, which consisted of 8 different programs. And return to baseline had identical procedures to the initial baseline with the AIM curriculum. The results for problematic behavior are depicted in these graphs. For Ben, his off-task behaviors remained at a stable rate that was comparable to initial baseline conditions. However, his verbal outbursts and non-compliance behaviors displayed a drastic decrease compared to initial baseline conditions, as well as throughout intervention. For Lizzie, she produced no significant changes in her behaviors, as both her off-task behaviors as well as verbal outbursts produce similar levels and variability as those depicted in her initial baseline conditions. Peter did display decreases in both his inappropriate speech and off-task behaviors compared to his initial baseline conditions. These are the results for the AQAS scores. Ben was able to reduce significant increases in his AQAS scores compared to initial baseline conditions, all which were stable responding. Lizzie did not produce any significant results, as her levels were also comparable to initial baseline conditions, as well as a declining trend for her return to baseline. Peter was able to produce significant increases compared to the responding in his initial baseline, though there was a declining trend observed. These are the results for the psychological flexibility assessments. All three participants were able to display targeted increases in their CPFQ scores. Lizzie and Peter displayed targeted decreases in their AFQY and CAM compared to initial baseline. However, Ben did display increases in his AFQY and his CAM. Some implications for this result for the study includes that the peak-T programs that format ACT into the DTT structure may serve as a viable treatment option for transitioning individuals with ASD into a less rigid therapeutic setting. Additionally, Lizzie's results indicate a potential prerequisite skills in language abilities and relational framing repertoires before being able to fully benefit from transitioning to ACT, as well as the ACT benefits. Some limitations for the study consist of the natural private nature for ACT sessions, which tends to lend to limited IOA being able to be conducted. Additionally, due to the academic setup within this clinic, there were some scheduling breaks which led to time constraints for transitioning these individuals from traditional ABA services of DTT to ACT, as well as limiting the amount of sessions that Lizzie was able to participate in. Additionally, Lizzie was considerably younger than her other two participants within the study, which may account for her lower peak-T pre-assessment scores, which indicate a lower relational frame and less complex language, which may help account for the results within this study. Another limitation was that Lizzie had a reduced mastery criterion for the peak-T programs. Ben and Peter had a 90% or higher mastery criterion, whereas Lizzie had an 80% mastery criterion, which limited her contact and experience with the ACT components within the DTT structure. Additionally, Lizzie was only able to master one peak-T program, whereas Ben and Peter were able to master all 8 before returning to baseline conditions. Additionally, another limitation is the multiple components of ACT and this study, which tend to lead to less reliability for replication, as well as identifying the most successful component in reducing problematic behaviors and aiding in transitioning to ACT therapy. Future research may want to consider evaluating the relational responding levels necessary for the most significant results for transitioning to ACT, Additionally, they may want to isolate acting opponents to see which are the most successful for aiding in transition, as well as identifying precursors for ACT therapy. Correlational studies may consist of QABF with peak T pre-assessments and peak T pre-assessments